In Unit 3, we will wrap up cardiopulmonary diagnostics with cardiovascular and thoracic interventions and monitoring procedures. These various techniques will aid in the completion of your research project too. In Lesson 11, we will learn about surgical and monitoring procedures that may be found in our clinical practice. These include revascularization procedures, coronary arterial bypass graft surgery, CABG, valve replacements, endarterectomies, AAA repairs, pacemakers, and defibrillators. We start our lesson with thoracoscopic surgery. It is used for pulmonary lobectomies, which treat lung cancer or lung reduction in COPD, lung transplantation, blood resection, or sympathetic nerve trunk destruction in the thoracic area, which may be used to treat excessive sweating, Raynaud's disease, and reflex sympathetic dystrophy. A newer technique to accomplish this is video-assisted thoracoscopic surgery, or VATS, which is minimally invasive and has many advantages over more open procedures. In addition to the above indications, it can also be used for esophageal and abdominal surgeries. Typical complications in thoracic surgery are atelectasis, pneumothorax, pneumonia, and respiratory failure, and the cardiovascular effects of arrhythmias and ischemia. These complications occur in about 15 to 20% of all patients and account for approximately 3 to 4% of postoperative mortality in open procedures and 2 to 3% mortality post-VATS procedures. Other advantages of VATS are due to the fact that only 2 tiny holes or ports are made with an access incision of only 5 centimeters in length versus large incisions with open procedures. With these smaller incisions, there's less pain, decreased inflammatory response, and blood loss resulting in shorter hospital stays. This slide illustrates the differences in VATS versus open thoracotomy. In the first figure, there are 2 small incisions with a scope that helps guide the surgeon to the proper area. In the second figure, there is a very large open incision. Common invasive monitoring devices for both open and VATS are arterial lines to watch for transient severe hypotension, usually secondary to bleeding, and CVP or central venous pressure monitoring for assessing cardiac output. We will go into further detail on arterial and CVP lines in later lessons. Percutaneous revascularization procedures is an umbrella term that encompasses angioplasty, arthrectomy, and stenting. Common to each of these procedures is introduction of a catheter under fluoroscopy via peripheral access route, such as the femoral or radial artery, into the coronary vasculature. The purpose of revascularization is to open a partially or completely occluded vessel. Treatment for occlusions of cardiac vessels not responsive to revascularization or in multiple vessels, particularly the left anterior descending artery, are treated with coronary artery bypass graft. Advances to CABG surgery include the use of ultrasound-guided imaging to help reduce the risk of dislodging plaques, and transmyocardial laser revascularization to stimulate new capillary growth and collateral circulation. Robotics are also being used, and the technique is called totally robotic-assisted endoscopic coronary artery bypass, or TCAB. Off-pump CABGs are also gaining favor as the benefits of allowing the heart to continue to beat during surgery instead of putting the patient on cardiopulmonary bypass machines and stopping the heart are becoming evident. These benefits include fewer arrhythmias, less inflammation, and infection. Working with patients with valve replacements are also the domain of the respiratory therapist. Diseased valves are diagnosed with either echocardiography or cardiac catheterization to directly visualize the valves. Diseased valves are either stenotic or stiff, not allowing blood to flow properly through them, or don't close properly, causing retrograde flow or regurgitation. Valves can be dilated with percutaneous balloon valvuloplasty, repaired with annuloplasty, which replaces the rims of the mitral or tricuspid valve, or replaced during CABG surgery. The aortic valve may be replaced with a relatively new procedure called TAVR for transcatheter aortic valve replacement, and involves wedging a new valve within the old valve, much like a stent. It is introduced via a percutaneous catheter, therefore it is minimally invasive. Ultrasound, CT scans, MRI, or MRI angiography may also be used to diagnose vascular disorders in the vessels leading to the brain or abdomen. In the case of carotid vessel stenosis, treatment may include an endarterectomy to prevent occlusions leading to stroke. Stents may also be inserted to keep the carotids open. In the case of abdominal aortic aneurysms, they may be discovered during a routine physical and in addition to the above tests may also be seen on chest X-ray. Aneurysms greater than or equal to 5 centimeters or with rapid enlargement are referred for surgery, called a AAA repair, particularly when accompanied by sudden abdominal pain. As discussed in Lesson 5, indications for pacemaker insertion are for SA node disorders, atrioventricular node disorders with bradycardia rates, and tachyarrhythmias such as SVTs with frequent PVCs. A new device that is currently in human trials is a wireless cardiac stimulation system, or WICS, that will use a tiny embedded ultrasonic receiver to regulate the heart wirelessly. There are 5 positions that make up a pacemaker code. They are the following. 1. Position 1, that refers to the chambers that are being paced. 2. Position 2 refers to the chambers that are sensed. 3. Position 3 refers to the pulse generator's response to a sensed event. 4. Position 4 refers to presence or absence of rate modulation or rate adaptive pacing. And 5. Position 5 refers to pacing of multiple cardiac sites. An implantable cardioverter defibrillator, or AICD, is similar to a pacemaker but detects and treats life-threatening arrhythmias including ventricular fibrillation and profound bradycardia. Patients with left ventricular ejection fractions of less than 30% have a 3 to 5 times increase in incidence of sudden death, but implanting an AICD reduces mortality rates by 50% when compared with medication alone.